Again, I'm Humphrey with Canopy, and I'm going to be talking about what we call a Radiology Concierge program. I was talking with Dr. Andy Schimmel, who is in the back of the room, and he told me he's done all kinds of research on this topic. So, now he's in the front of the room. So he's coming up to like put me right in the crosshairs and pick it apart if I'm sure he knows a lot about this kind of stuff. But anyway, so this is a topic that we got a lot of requests from last year to talk about this. For those of you that were here last year, Dr. Dan Intrican and Dr. Jay Watts from Greensboro Radiology gave a talk about what Greensboro is doing to improve quality, to be innovative, to really be progressive as a group. And one of the things they've done is to try to, as much as possible, take things off the plate of the RADs and to free them up to focus on practicing at the top of their license. So among the ideas that they threw out last year was the concept of a Radiology Concierge Service, which Greensboro has in place and has used for the past 8 years. There were a lot of questions around that, so we said, all right, well, we'll unpack it a little bit more and talk about it this year. So a Radiology Concierge Service, I'm sure that's a new term for some of you guys. So some of our learning objectives are, we'll explain what that actually means. We'll define the problem and solution. We will talk about how to build a program like this, whether you outsource it or build it in-house yourself with the right people, the systems and processes. And then we'll spotlight the Greensboro Radiology case study because they've been doing this a long time and you can really see kind of what the results and the fruit have been. We'll show some specific metrics and then we'll just take some Q&A. Okay? Let me grab the clicker here. So the problem we're trying to solve is simply the fact that radiologists are being asked to do more with less. There are increasing administrative and compliance burdens on RADs. They have to serve multiple customers, hospitals, referring physicians, patients, provide all kinds of clinical documentation on things, make sure that everything is coded properly. And they get frequent interruptions and distractions in their day, and it pulls them away from being 100% focused on their main job. So the solution is let's see if this is working. It is, okay. So basically we want to free the RADs up so that they can practice at the top of their license. Not working great. I'm just going to do it manually. Okay. So I'm sure many of you are familiar with Stephen Covey. Stephen Covey has written books about how to manage your time, 7 Habits of Highly Effective People. One of the things that he talks about, and it's about a 30-minute YouTube clip that I'm going to distill down to about 30 seconds, is the concept of putting big rocks first. And you can see here with these two mason jars that you have the exact same rocks and sand. But by putting the sand in first, there's not enough room to put all the rocks in, and therefore the big rocks, i.e. the important things, there's not enough time to do the really important things that matter because there's all the small stuff that gets in the way, okay? In the other jar, the rocks were put in first, and then the sand was poured in on top of it, and the sand fills in around the cracks, and you can actually fit it all in when you start with the big rocks and the important things first. So at a very simple conceptual level, what we're trying to do here is allow radiologists to focus on the big rocks and to eliminate some of the sand or delegate it so that there aren't as many distractions and minutia and administrivia that's slowing them down in the course of the day. So a quick introduction to Greensboro Radiology. I know many of you groups know who Greensboro is, but a little bit about the practice. Greensboro is an independent practice. They're based here in North Carolina, about an hour away. They have 70 radiologists, 4 PAs, read over 1 million studies per year, have 10 hospitals, more than 50 referring facilities that they read for. It's a very highly subspecialized group, pretty innovative, and the group has been ranked in the 99th percentile nationally in referring physician satisfaction scores by Press Ganey. And that's relevant here because this is not only something about freeing up the radiologists and helping them to focus and be more efficient, but it's also about providing better value, better service to your hospitals, to your referring facilities and physicians, that you serve, it's better for everyone. So again, Greensboro is based in the Triad area, about 1 hour from here, serving Greensboro, Winston-Salem, and High Point. So what is a concierge program? So very simply, it is by combining technology and services to take some things off the plate of the radiologist. The two primary things that we use in this environment that we created here at Greensboro is a unified work list. We use the Clario Z-Vision work list. And then professional radiology assistants, which we call PRAs. And they're the actual secret sauce behind the scenes that are taking phone calls and taking things off the plate of the RAD. So, we kind of believe in combining the technology and services, you get the best of both worlds. So it's kind of like a Reese's cup with the chocolate and the peanut butter together. It's better when it's together, and if you do it right, you might even get some Reese's Pieces in there to kind of spice it up a little bit. So the key components of this program that we've built here, you wouldn't have to use these exact things, but this is kind of what makes up the backbone for Greensboro Radiology. The Clario Z-Vision work list is the big dashboard that kind of sits over top of everything. It's the main system that the professional reading assistants use. The PRA staff themselves. We have a call center operations set up that's centralized. Obviously, the PACS and the VR and the facility-based products that are in use, because in order to help the RADs, you have to be able to see the exams they're talking about. You have to be able to access the call reports. You have to be able to see critical results and things like that to be able to provide some of these functions. Other components would be the scheduling software, some Comm Note tracking, and some instant messaging. I'll spend a few moments on the instant messaging because it's a really simple technology, but it helps a lot being able to get right to the RAD that you need quickly. So a bit about the Clario Z-Vision work list, and I'm not going to spend a lot on this, but obviously Clario is here at the conference, and they've had a booth here. Many of you are familiar with their product, and we've been using it in this area for Greensboro for, I guess, about 3.5 years. And it really made a huge improvement in productivity. In fact, the day that it was turned on, Canopy had set up a war room to be ready to take the calls from all the 50-plus referring facilities, expecting that something's going to go wrong, right? I mean, like when you do a big bang launch and you turn on a Clario across your entire enterprise, you better be ready because something's not right, system's down, somebody doesn't know how to log in. So we set up this war room with like 10 people ready to go from wherever the calls came in, and it was crickets all day. It was just quiet until about 3:30 in the afternoon, and then RADs start calling in saying, I think Clario's down. We said, it doesn't look like it's down. And they said, no, I think it's down. I don't have any exams to read. And we were like, the list is just clean, right? Instead of it being 5:30 and they've got 20 exams still to read, the list was done at 3:30 in the afternoon because the system is serving up exams, the right exams to the right RAD, and helping eliminate the cherry picking and downtimes and keeping things moving. So it's just a really effective system, that's something that's been a real key. Just to give you an example, one of the things that you can do with the Clario system is you can workload balance across your staff. And in a group like Greensboro that's got 70 radiologists, there could be a day where somebody is sitting out in a remote site and they've got time on their hands and they could read some exams. But how do you get the exams to them? How do you know that that they've got that time? The system is monitoring that and says we can feed more to this person today or shift them from here to there and workload balance. So a few examples of just some results from a turnaround time perspective. ED stats by implementing workload balancing have dropped from 12 minutes 12 seconds to 7 minutes and 45 seconds. 4.5 minute improvement, or 57% improvement in turnaround times. Inpatients actually gone up a little bit, and that's actually kind of by design because the group would like to spend a little bit more time on inpatients and make sure that they're really paying good attention to those. And then on the outpatient, got to turn a lot of volume, and by having the workload balancing, the outpatient turnaround times have gone down 34%. So the total impact on turnaround times, and this is just one measurement, has been 35 minutes and 25-second improvements in turnaround times. So a little bit about the professional radiology assistants. We have a staff of 6 people in place that are serving just the Greensboro account. They're dedicated to that account. We have some other clients that are here at the conference that also use this service, and we try to have reading room assistants that are dedicated to a particular client. And they know your staff, they know your schedules, they know your workflows. So the reading room assistants, the professional radiology assistants, really they get to know your practice. They're able to really take the calls that would have normally come into the radiologist. And one of the real kind of secret sauces in this whole thing, and it sounds so simple, but we've just put in one phone number. Literally one phone number, and it gets you to this covers anything within Greensboro Radiology's enterprise, more than 50 sites, more than 1 million exams, one phone number. If you need to get a hold of radiology, here's a phone number. It's a toll-free phone number, and we'll get, the PRA will answer the call. They typically answer the call on the first ring. They answer it live, and then they'll figure out what needs to be done and figure out what RAD they need to get it to. Or the RAD can communicate to the PRA, I need you to get Dr. So-and-so at this ortho practice on the line. I need to talk to him or her and go over something with them. Well, the RAD can be working and just say either instant message or pick up the phone or send a message through Clario and say, I need you to get Dr. So-and-so on the phone. The PRA will take off and start working on that. And it may take them 15 or 20 minutes to get that doc on the phone, but the RAD's over here continuing to work. He or she's not having to chase that person down. And then when that doctor is available, the message will come back in from the PRA. Okay, I've got Dr. So-and-so on the phone. Can you talk to him now? Yep, great. Hey, Dr. So-and-so, this is what I got going on, right? So no wasted time. The RAD can just keep moving, and there's somebody kind of handling this blocking and tackling for him. But having that one phone number has been a real key. It's just great for, it's easy. Everybody has that one number. Publish it all over the place. Instead of 50 different numbers and well, if I'm at this location today, then call this number, but you have to call this department and you have to come through the switchboard. You know what, just use my cell phone, right? And then numbers just get out all over the place, and it's really hard to keep that centralized. So this one phone number's made a big difference. How do we handle nights and weekends? That was actually kind of a trial and error. Had to kind of figure out the best way to handle that, because quite frankly, it's hard to find people that want to work those shifts, and you have to pay them quite a bit, and there's a high risk of burnout or turnover, right? So that equation wasn't working that well, but we needed coverage there. And so what we ended up doing is we found a call center in the Philippines that is set up. They speak really good English. All they do is health care call center support for companies in the U.S. They've done an excellent job. So we turned this on as a pilot, and I think we had 3 or 4 people that were trained. And when we got ready to turn it on, we turned it on as a pilot, ran it for 3 or 4 months, and said, "This is going great," And so we just kind of grafted it in, and so we've got daytime coverage being provided domestically, and nights and weekends being provided in the Philippines, and it keeps the cost down. And if they have a turnover or a training issue or whatever, they deal with it. So this has been a really good way to address that and provide not only one phone number, but 24/7, 365 coverage. So some of the services that are being offered, and in your environment, this would probably be different. You can customize what types of things you'd want your PRAs to be doing for you. But some of the things that Greensboro has their staff do, obviously handling phone coverage, getting high priority messages where they need to go, instant messaging, Comm Notes, critical findings, call reports, finding the referring physicians, a lot of documentation of things that just require updating things in the system, contacting the techs for missing images, ultrasound worksheets. Hey, I'm trying to read this case, but there's no clinical history with it, but the notes reference some history. I need to see that clinical history. Can you go find it for me? Let me know when you've got it, and they'll go pull it out of Epic or something, right? So it's just these things that can sidetrack you, that you've got somebody there kind of riding sidecar that can help you get these things done. The nerve center of the system is a portal that is accessible to everybody within the practice, the physicians, the PAs, the techs, as well as the PRAs. And we call this RAD Info Portal. And RAD Info Portal has got all kinds of great information, telephone numbers, different programs, training guides, announcements, updates to things. All the information that you need is in one place, and it's HIPAA protected, it's secure, it's behind the firewall. You can find every phone number for referring docs. You can sort it by last name, first name, specialty, the practice that they're in. Very easy to get those phone numbers. And obviously this is being constantly updated as new docs come on board and people move from place to place. So this is a living, breathing portal that every day we're kind of caring and feeding for it. It's not a static thing. Obviously reading room phone numbers for all the different locations that are served, various clinical policies, and you're constantly updating as new things come in and taking out things that are no longer relevant. So you keep everything current and in one place, and it provides a centralized repository for all this information, and then the PRAs can access this and help do some of the things to take work off the RAD's plate. So all this is basically designed to help the radiologist be more productive and efficient and help to get the right read to the right RAD at the right time. So, if we needed to get an MSK study to a doc that's on call right now, we know exactly who's on call. It happens to be Dr. Bill Veazey, who happens to be sitting right there over there in the room. So if everybody in the room, this exam's going to him, all right? So this is kind of the instant messaging piece, and you can see here that we can see all the PRAs. This is like a dashboard that is everybody uses this, okay? And we're all online real time. You know who's available, who's not, but you can see which PRAs are working right now. You can see the IT help desk numbers if something's not working right with the PACS. You can punch out and get help there. You can see the docs that are working, and you can actually see, like right now, there are 35 online or 35 concurrent docs that are working, okay? You can see who's working, exactly where they're working, what facility, what department, what desk are they at, what phone number, are they available or away? Maybe they're out talking to a patient, maybe they're having lunch, maybe they're at a tumor board meeting. But you can see exactly what their status is and whether they're available or not, so that you can know, okay, so right now I need to get this to Chris, or I need to get this to Mike. So it really helps to be able to see in real time, and this is constantly being updated. As a physician logs in at their particular location, then this profile kind of comes through, right? And tomorrow, if they move to another site, it'll tell you, okay, now they're working at Cornerstone. So having this in real time is super helpful. And then you can see what sections people are in. If you needed to get a body exam somewhere, you can see there are two body docs that are working. And then if you needed to get a message to somebody, for example, if a RAD said, I need somebody to get this call report out to a doc for me. So you click on the Comm Notes right here, and then there's a drop-down menu list. This is customizable, so you can configure it to the most common things that your staff does. But here, there's just a drop down for, I need a call report sent ASAP. The doc's requesting this. And then it'll pull up, this is the call report that I want you to send. And then down on the bottom here, you'll see these results will be called in, called to the ordering clinical representative by the radiology assistant. And then the communication will be documented in the PACS or the ZVision dashboard. So all the doc has to say is, I need a call report ASAP. Boom. That call report with the relevant data is sent to the PRA, who's going to take care of this, call it in, and then document it in the system, right? You're done, and you get back to reading the next exam. So let's talk a little bit about some of the results that we've seen, some tangible metrics. Again, this is a program that's been in place for 8 years, so we've had a long history to kind of evolve it and really, become heavily reliant on it. I think the Greensboro radiology docs would tell you, once you go here, you're never going to go back, right? It's just a game changer. So some of the metrics, on an annual basis over the past year, there have been 57,400 calls handled by the PRAs. Most of those would have come to the RADs previously. The calls are answered 98% of the time by a live person. The average speed of answer, 6.5 seconds. So that's fantastic service, right? I mean, somebody calls, we've got somebody on the phone typically in the first ring, 6.5 seconds. The average call time is about 2.5 minutes. So the total talk time, 2,143 hours on an annual basis that was taken off the RADs. If you try to break that down to an ROI, 2,143 hours equals about 225 radiologist shifts. And at Greensboro, their group averages 9.5-hour shifts. Okay, so that's how I'm coming up with that number. It's the equivalent of 1.125 RADs. Sorry, let me go back. So the average radiologist shift for a year is 200 shifts. Okay, so if we're taking the equivalent of 225 shifts in phone calls, then that's the equivalent of 1.125 RADs. It's pretty easy to show an ROI. You know, you can hire a couple of staff to handle this when you can justify more than one RAD. The efficiency gain just from phone calls is 2.3% efficiency gain. In terms of total, radiologist time, available time based on 9.5-hour shifts, we freed up 2.3% of their time by taking the phone calls off of them. And that's just the phone calls. On the Comm Notes, which is different than phone calls, 19,860 Comm Notes. We track and measure things like the SLAs for stat turnaround times, call report completion, how long it takes to contact techs. And actually these numbers have moved. We started with certain targets and have kept tightening them up and improving them over time. So, for example, the stat turnaround times used to be 20 minutes, now it's 10 minutes. The SLAs for contacting techs used to be 30 minutes, now it's 20 minutes. So as we're getting better and better, we're closing the gap and actually providing better, faster response. So how do you implement a program like this? There's a number of different ways to do it. I'll just kind of show you how we've done it in this case. But again, you can build this yourself. Maybe some of you already have a function like this. But if you don't, I would highly encourage you to look into it. But you can build it yourself. You can outsource it. We're happy to be an advisor and tell you what we've done or help you in some way. But it's not rocket science. It's pretty simple. Basically, you've got to focus on it and decide this is what you want to do. You've got to be willing to make an investment, assign a project manager, develop a statement of work. You've got to license and install all the appropriate software that's needed to do this. And of course, we could help you with that and tell you what that, make some recommendations there. Provide a central toll-free phone line, determine the hours of coverage and how you're going to handle the nights and weekends. And then you've got to recruit, hire, train, and manage the PRAs. So that's pretty much, how you would do it. And then the harder part of this is getting the RADs to agree to the workflows and the protocols. How are we going to handle things, right? There's a lot of complexity, especially the larger your practice is, there's the more variables. And we've got to come together on how this stuff's going to be handled and what are the right procedures. So determining your workflows and protocols, building that online knowledge base. If you haven't done something like this before, the information lives everywhere. It's all over the place. How are we going to pull all that information together and get it in one spot, right? And commit to keeping it updated. So you've got to get schedules. You've got to get all the referring physician phone numbers in there. You've got to keep up with all that kind of stuff. Set radiologist preferences. How do we want to handle things like a code stroke when it comes in? Things like that. So you've got to determine your business rules. And then once you've got all this, then you just need to test it like crazy before you go live. This is not one of those things that you just flip the switch and your world changes overnight. It's going to be an evolutionary kind of a thing. And you really want to kind of crawl before you walk, before you run as you're rolling this out. So again, in conclusion, all this is just to kind of help the radiologists be radiologists, to practice at the top of their license, and to focus on putting the big rocks first. I think that's it. Do you all have any questions? Yes.
A couple questions. So number one is for the 57,000 plus calls. How many PRAs? What's the background on the PRAs? Are they medical assistants? Are they clerical? And the third part is there a quality feedback QC for the actual matter, the end user, whether it's the referring physician or the referring physician's office, and the PRA. So I just want to do a deep dive into that.
Those are great questions. I'm going to give my take on it. Dr. Veazey, I may call on you as well because you interact with them a lot more than I do personally. But in terms of the type of person that you're hiring, it's typically someone that's a little bit more clerical, that is able to take phone calls, route them, send a quick message, those kind of things. If they've got a nursing background or a healthcare background, it's helpful. They're going to understand the concepts a little bit better. But it's not rocket science. I mean, it's very simple blocking and tackling things that you're hiring someone that might make, $35,000 a year with benefits, it takes a little bit of training to get them up to speed and show them how you want things done. And then you just got to kind of monitor and manage them. In the Greensboro environment, just based on their size and scale, there are 6 PAs. There's a team lead that sort of kind of oversees and makes sure everybody's doing what they need to be doing. And then not all 6 PAs are working, at the same time. So there might be 3 or 4 that are working at a given time. And that's covering the daytime hours. And then in the evening, there are, I believe there are 4 offshore that are covering the evenings. The call volume is not as heavy, but you still need that coverage. So I think we have about 6 on staff during the day and 4 overseas during the evening hours. So Dr. Veazey, do you have anything to add to that?
Well, just that they follow those metrics constantly, and we have to update the coverage, based on the turnaround times for the calls and such. Regarding the medical background, it would be nice if they did for call-in reports. We do not like radiologists to have the PRAs call reports to the ER physicians. It needs to be called to them. We call it ourselves because they don't want to talk to the PRA about it. And a lot of the calls they make are to another non-physician anyway, so it's okay. But if they really want some, medical to medical communication, then we ask them to just give the call back to us because they don't really want somebody reading a report to them necessarily. So a physician doesn't want to get that. So that we've had some pushback on that recently, and if you're going to be calling directly to physicians, you may not want your PRA doing that all the time.
That answer your questions?
I would add just a couple of things, Ms. Manor, with that. From your perspective, looking at it, 57,000, I would actually think about it more like probably 4. So these people, most of them were previous transcriptionists. So what you need to know, they need to know how to say the words. They need to know how to understand the words, etc. Where they worked, one worked in an orthopedic office and did a bunch of stuff around there, so they have that familiarity. In our practice, the reason I say 4 instead of 6 is because there's also some legacy work that's being done at other sites where they're running around and doing some other mammo stuff or helping out. So the person that's at this particular site might only actually spend 50% of her time doing this work.
So they can be cross-trained.
So that, yes, they are. So we've got at some of our peripheral sites some duties that need to be done that this team is also taking care of. We've got people at our central site that this is all they're doing is answering calls. So it's a little bit less.
Other questions? Dr. Schimmel, I teed you up in the beginning that you'd done some research on this in the past. Any learnings that you have there? Any thoughts or best practices?
No, we basically just had to, we attempted to quantify where I trained what we had perceived and what you have touched on, the fact that there's interpretive skills and non-interpretive skills, or tasks, I should say, that occur in the reading room. So we tried to figure out just how much time each one of those took and demonstrate that they're actually discrete workflows and should probably be handled discretely as opposed to relying on one person to do it all. So, yeah.
Cool.
Yeah.
Great.
So Reed, we obviously you read for us, and the technologists love the PAs because it's so much easier for them too. When they have a question, they're not trying to call 15 reading rooms and chase down the doc. They can call the PA. A lot of times PA can just handle it, and it's also nice when we got a doctor who walks into our hospital looking for an MSK radiologist, and we used to have to tell them, well, there's not one here, let's see if we can find you one. We just call a number for them and say we need to speak to so-and-so wants to speak, and they just transfer it. So from the, I guess, your customers end, it's really good too. It's made our lives a lot more
That's a great point. And Gary is the radiology imaging director for a hospital that Greensboro reads for. So that's great to hear from that perspective. Dr. Matter?
I would flip one of your numbers around a little bit too. I've had a lot of conversations with people over the last couple of days. How do you get your docs to be willing to pay for something like this? So you put up a number of 2.3%, you know, as we've looked across the country, and there's different areas, but all in, let's say, you know, the cost of radiologists with benefits is $750,000. Let's take that 2.3 down to 2%. That's $15,000 of efficiency time that your doctor is using, sitting on the phone, waiting for somebody to get a hold of them. So now go back to your doctors and say, hey, y'all don't mind if I just drop your salary by $15,000 because you're spending $15,000 of the group's time making these phone calls. We can go hire these people, or you can just all pay back into the group $15,000 because I can get this for you for a lot less than 15 per doctor.
Yeah. And the 2.3% is just the phone calls. I think when you put the whole thing together, I asked Dr. Krishnan if he could quantify what the total ROI has been for the whole concierge program that we're talking about. He said easily 10%, if not more. So that was just one hard number that I had was at 2.3%, but it should be a fairly easy sell.
I need to get around to quantify it, but I think as radiologists, we're just not, you know, a lot of groups are thinking about running skinny and all these kinds of things, and like, you know, when you really get down to it, you start taking a look at all these lost dollars, and Leah will tell us forever about all this stuff, but you know, that there's a lot of money out there on the table that we've just said, yeah, give me more, put more rocks in my backpack, I'll do it. When, you know, you can be doing better stuff.
Yeah. Dr. Brown?
I just have a question for those of you that are using Greensboro. So you can see the list that everybody who's active on the system. You guys always check out when you're doing a procedure or away from that phone to show the PRA that you're not immediately available?
So it actually just times out. If you haven't been active on it for, you know, if it hasn't seen you do anything for, and I don't even know what the time is, 15 minutes or 20 minutes or something, it goes from green to yellow. Okay. You can manually change it. But.
And then do you internally have a policy to mandate people to pick up the phone? Not that, maybe I'm the only group that has people that don't like to pick up the phone when they're trying to be reached by certain people, but do you guys have any issue when the PRA is calling to get a hold of, say, a neuroradiologist?
So I don't know if we have a way to quantify that or know that. Maybe Bill could get it.
Well, the phone is ringing much less than it used to because it's all the calls are going to them first.
But I mean,
so
when the PRA
when the phone calls, it's somebody. It's either another radiologist that knows you're sitting there, or it's one of the PRAs. So I would say that there are occasional problems, especially towards the end of the shift, like when or if you're working past your shift, you're trying to help out. And you're, don't call me now. I'm just here helping out. But for the most part, I think people understand the benefit of it and realize that they're calling you to make our job easier in the first place.
Your PRA say the opportunity to give you feedback to say, hey, so-and-so always gives me trouble answering the phone. I'm trying to get a hold of them. Yeah, so you guys have
I get all those complaints.
Yeah, so I don't know that we would know if somebody wasn't answering a phone. I don't think that's really the biggest problem, but you do get that direct feedback of, you know, every time we call Dr. Beasy after 5 o'clock, he is a jerk. And then we got to go talk to Beasy again.
So I talked to Dr. Lee Hall, who's a neuro-rad, and he said that the neuro-rads used to get crushed with the phone calls because everybody else kind of floats and moves around. So they're not always in the same seat all the time, but the neuro-rads tended to always be in the same spot. So everybody knew that if you really need to get a hold of radiology, call the neuro section, right? And so they were just getting distracted all the time. And now everything rolls through the PRAs and everybody gets a lot less phone calls, but it's actually shifted the paradigm to where now you're not trying to avoid or hide or I don't want to answer the phone, I don't want to be distracted, to you're conditioned to, if the phone rings, I know it's important and I need to pick that up because it's only going to ring 2 to 3 times in a day, right? And it's the PRA saying this is what we need, right? So it just changes that mindset and it moves you away from avoiding the calls.
And to that end, I'm one of the neurorads, and if they need a neurorad specific question, they actually kind of rotate around. So they know, okay, today we've got 3 neurorads, and now I'll call Matter, and then I'll call Hall, and then I'll call this, and at least they tell me that's what they do. But, so hopefully they're sharing that out a little bit more. We'd probably get more than 2 to 3 calls a day, but it's certainly a lot less.
Any other questions? Okay. Well, thank you guys very much. Appreciate it. And we'll see you back.